Yeah. So this again a female patient, emulsified silicone oil in the anterior chamber. So I made two paracentesis tracts again under topical anesthesia. These eyes tend to be soft, so sometimes it may be important for us to firm up the globe by injecting BSS or OVD into the anterior chamber. It was not necessary here. Before performing capsular Rhexis, you perform the emulsified silicone oil BSS exchange. If the eye is soft and if you have not performed this maneuver, you are likely to end up with a long clear corneal incision, and that will have problems like overlocking, corneal striae, and a lot of difficulties during intraoperative manipulations. Staining the anterior capsule with trypan blue dye is important because there may be fibrotic plaques, fibrotic patches, which you might not have seen on the slit lamp examination, like once the pupil has dilated fully on the during the surgery. See, for example, these areas of where you see those pigmented patches, they may have fibrosis around it. So when I perform the capsular Rhexis here, I'll make sure that I go peripheral to these areas so that I don't have to really deal with these potential fibrotic patches that may come up here. Another point I would like to emphasize here is this is a second surgery. There have been silicone oil in the anterior chamber and endothelium requires to be protected. So you need to use a good quality dispersive OVD, and I always use a soft shell technique routinely for all my cases. So this is something I wanted to emphasize. Cortical cleaving hydrodissection in this case is okay, but in certain situations where post-vitrectomy white cataract or post-vitrectomy sudden progression of the cataract, potential damage to the posterior capsule, or the surgeon has told you that there has been some touch to the posterior capsule. In those cases, I would not perform cortical cleaving hydrodissection at all. There are different ways of managing those cases. Now, the nucleus removal, whatever technique you follow, before that, these eyes tend to become very deep. So now this is a trick that you need to follow to how to avoid the reverse pupillary block. Before you engage irrigation on the foot pedal during Phaco, you just elevate the iris from the anterior lens capsule. So there is pressure gradient equalization between the anterior chamber and the posterior chamber. The anterior chamber does not become deep at all, and the rest of the surgery goes up in a very routine manner. So here, employ a technique which you are comfortable with. Your Phaco disassembly technique has to be zonule friendly. So for me, my routine surgery is I just make a little crater or a small tunnel and then start chopping. But if you're comfortable with stop and chop or divide and conquer, or whatever technique you follow, that is okay. Just ensure that you do not traumatize the zonules, because many of these cataracts come to us with a very advanced cataract, the nuclear sclerotic cataract, zonules may be compromised. So it is very important that you take care of that. Because of the siliconal in the posterior segment, they can be siliconal upthrust. So during the last piece removal, it may be a good idea not only to step down on the Phaco parameter settings, but use visco expression for the last segment. Same thing about the epinucleus removal. We do not allow the anterior chamber to become shallow. As you see here, I always maintain the irrigation in the anterior chamber. I always prefer a bimanual irrigation aspiration for my routine cases. It slows me down, but it is definitely more. It can be done in a more controlled manner. Here again, you have to worry about the posterior capsular damage because of the siliconal upthrust that may come. And this is one situation where I'd like to polish the anterior capsule, scrub the epithelial cells under the anterior capsule as much as possible. There are few other situations where I do it. For example, complicated cataracts, a patient with pseudoexfoliation, retinitis pigmentosa patients, because these patients tend to get a lot of fibrosis, capsular bag fibrosis, Rhexis phimosis, decentration of the intraocular lens. So I do spend a lot of time dealing with the anterior subcapsular cells in these situations. You see patchy opacities, usually you see fibrotic plaques, but in this case, patchy opacities, it really doesn't matter. And at the end of the surgery, of the cataract surgery, the posterior segment surgeon has removed the silicone oil from the posterior segment. So I didn't really have to alter the intraocular lens power. These eyes, again, it is important that you put a tenon island suture to the main incision, because these eyes tend to be very soft at the end of the surgery, and the self-sealing corneal valve may not really work. So there are different ways of managing post-vitrectomy eyes, and this is one such case that I just showed you.
Yes, that was a truly teaching video. There were very few questions. I had quite a few questions. You answered most of it. But one good thing, I hope all of us saw that how he dealt with iris retropulsion, which can happen in these vitrectomized eye, how we just lifted up the iris so that it gets lift off the lens capsule. I would say that we need to be careful about the hydro, because sometimes lens touch could happen, and some of these cases are referred to us from elsewhere where we do not have a communication from the surgeon. The only other thing I wanted to ask you was, some of these cases have a PC plaque, these post-vitrectomized eyes. If the silicone oil is already still there in the eye, would you ever go about doing a PC polish, or would you like to peel off the plaque, or would you let it be like that?
Thank you, Chitra, for asking this question. For example, unlike a post-polar cataract, if you have a very significant plaque at the center, and you have silicone oil in the posterior segment, and it has to be retained as per the posterior segment surgeon's advice, and it is not amenable to YAG. It is a thick fibrotic plaque. So I will do a central posterior capsular Rhexis, and I will capture the optic through the Rhexis behind the posterior capsule, through the posterior Rhexis behind the posterior capsule. If you don't do that, in few days' time, you see the silicone oil which was there in the posterior segment comes all around, and it comes to the anterior chamber. So I perform a posterior capsular Rhexis in those cases. We capture the optic through the Rhexis, so it is now against the posterior capsule, and that prevents the silicone oil from coming forwards.
That was well answered. Shall we go on to the next video, or Rohit, I seem to keep preventing you from asking. I don't know why I've been so stickler about time.
Just
Dr.
one question.
Arup, just quickly,
Let me have Rohit.
like what do you do with the IL power calculation?
Yeah, exactly. That was the question everybody wants.
Yeah.
So that is a very interesting question, So there are two things. One is calculating the intraocular axial length, and then second thing is choosing the intraocular lens power. So for all vitrectomies in my center, we do optical biometry before the cataract, even if it is a clear lens, and we keep it in our case sheet, and a copy is given to the patient for his safeguarding there. So if he goes elsewhere, so if you have silicone oil in the posterior segment, optical biometry is the way to go about it. In certain situations, optical biometry may not really help you, because if you have a thick posterior subcapsular cataract, or if you have a nuclear cataract, and these patients tend to come with this kind of cataracts, so then you may have to resort to ultrasonic biometry. All right. So if I have done an ultrasonic biometry, I'll assume a siliconal velocity of about 980 millimeters per second, and use a factor of 0.71 and multiply it to the axial length that I have got. I mean, if I know what exactly is the centistroke of the siliconal that has been used. Now, this is in regards IL power calculation. Now, what power am I going to use? Because silicone oil in the posterior segment acts as a negative lens. So, so it has got a lower, higher viscosity than refractive index than the vitreous. So, if I'm going to remove the silicone oil at the same place, same sitting, I would use IL power, what has been calculated. On the other hand, if I am going to retain the silicone oil for a long period of time, if it is, most of the lenses are biconvex lenses, so I'll increase the power by 6 diopters for IL power less than 24, and IL power more than 26, more than 24, I'll increase it by 8 diopters. If it is a meniscus lens, or if it's a plano-convex lens, and these are not available to us any longer, you don't have to. With the plano-convex, you have to increase the power by 3 diopters. But at the same time, you must tell the patient that after the silicone oil is removed, you are going to have a hyperopic shift. All right. So that has to be, you're going to have a myopic shift. Sorry. So that has to be.
Anytime go for piggyback IOLs?
No, I have not really gone for a piggyback IOL. I mean, I have followed this dictum, and so another option would be, if you are not very sure, you could, keep the patient aphakic, and at the time of silicone oil removal, you can calculate the intraocular lens power and implant the intraocular lens.
Fine.
Thank you very much.
This is a large, big topic,
Yeah, very well done.
Yeah.
Both the videos were very well done.